Hi all, welcome to Raaonline. Today we are going to deal with one very complex topic, that is hybrid arch repair. Whenever aortic arch is involved, it is going to be really complex, and here hybrid means you are going to do some part with surgery, some part with the endovascular repair. Introduction of thoracic arch endovascular repair started way back in early 1990s. Commercial availability of different type of stent graft made it possible for arch aneurysm, and hybrid procedure includes TEVAR with conventional elephant trunk repair, TEVAR with open debranching of cerebral vessels, and TEVAR with extra anatomic bypass. These are all the various hybrid procedures which can be done for aortic arch, and this hybrid procedures have simplified the aortic arch reconstruction and made aortic arch repair feasible in high risk patient with lot of comorbidities. Coming to the anatomy, you have abdominal aorta and the thoracic aorta. Piercing the diaphragm, it becomes abdominal aorta and thoracic aorta. And thoracic aorta comprises of annulus, ascending aorta, arch of aorta, and the descending thoracic aorta. And this descending thoracic aorta can be upper thoracic or lower thoracic. Just distal to subclavian is upper thoracic, and after 3 cm it will be lower thoracic. And abdominal aorta can be upper abdominal, middle abdominal or lower abdominal. It can be further divided into suprarenal or infrarenal. This part, this is the renal artery. Suprarenal or infrarenal will be a better classification for abdominal aorta, and this anatomy is very important. Now coming to the thoracic aorta, you have the ascending aorta, arch of aorta, and the descending aorta, and just above the annulus you have the right and left coronary arteries, and from the arch of aorta the various vessels which arises is very important. You have the brachiocephalic artery which divides into right subclavian artery and the right common carotid artery, and from the arch you have the left common carotid artery and the left subclavian artery. These arteries are very important when you have an arch aneurysm. When you repair around this part, you have to provide blood supply to all these three vessels, or when you are dealing with this, you have to place some form of conduit so that the lower thoracic aorta receives blood supply. So, anatomy of these branches plays a major role in the repair of arch. And when you consider stent, you have to know the landing zones. Okay, and there are various landing zones. One of the most important classification for this zone is the Zimura classification. You have zone 0, which is between the ascending aorta and the innominate artery, that is zone 0. Zone 1 is your between innominate artery and the left common carotid artery, and coming to zone 2, it is between the left common carotid artery and the left subclavian artery, and zone 3 is just distal to the left subclavian artery is zone 3, and it can be further divided into 3 and 4, where immediately after subclavian artery is zone 3, and after 2 or 3 centimeter it is the lower thoracic aorta, which is called the zone 4. And this zone 0 is further subdivided into A, B, C. Zone A is between the annulus to the coronary arteries. Zone B is from the coronaries to the right pulmonary artery, and zone C is between the RPA to the innominate artery. So, zone 0 is further subdivided into 3 subzones, that is A, B, C, and these zones are very important for the launching of the proximal part of the stent. So, from the anatomy, these zones are important for placement of the stent graft, and the branches are very important for placing the surgical part. So, this part is for the endovascular part, and this part is for the open surgical part. This is called the hybrid surgery. You have open surgery as well as the endovascular component coming into picture. And this is ME arch replacement. Just distal to the innominate artery, you replace the arch. That is ME arch replacement. And you include the innominate artery and replace it. It is called partial arch. And total arch is all the three vessels which arise from the arch are being replaced. That is total arch replacement. So you have ME arch, partial arch, and the total arch replacement. And what is elephant trunk? It is a trunk-like thing which is placed in the thoracic aorta, and you have a fenestration which is left for the subclavian artery, and this non-metal portion, this part is anastomosed to the prosthetic graft, that is elephant trunk. So what are the various options which is available for hybrid arch procedure? Here you have an aneurysm of the arch as well as the descending thoracic aorta. So what are the various options? You have to look at the blood vessel. Right brachiocephalic, left common carotid, and left subclavian are the vessels which arises from the aneurysm now. What we are going to do is just replace this aneurysmal part, that is interpositional graft. That is the simplest of the surgery. You do a surgery and place a graft here. Okay, graft is being placed. It is anastomosed at the proximal end and the distal end, and the three vessels are also anastomosed to the graft, and the distal end is being anastomosed. It is an interpositional graft with head and neck vessels inserted as an island. That is a simple procedure. Now coming to one stage repair, where you do a large conduit. Okay, the conduit is replacing the entire thoracic aorta from the proximal to the distal end of aorta. You put a one conduit and you do the proximal anastomosis, you do the three vessel anastomosis and the distal anastomosis. This is the one stage repair with only surgery. Here you do only the surgery, proximal, distal, and the vessels are anastomosed. Now coming to classical elephant trunk, stage 1, you put the conduit and you put an elephant trunk. Okay, this is an elephant trunk stent graft where you have a free end. Now coming to stage 2, that elephant trunk, you do a surgical completion at the distal part. That is stage 2 cerebral tension, and you do a proximal anastomosis, and the classical elephant trunk stent remains in place. This is stage 2, and stage 2 is completed with the surgical graft at the distal end. Another important thing is in stage 2, you can do a stent completion. Instead of surgery, you can do a stent completion at the distal part, and this is called the free end classical elephant trunk surgery. There is a stent inserted in the distal part, and this is the distal landing zone. Then what is frozen stage 2 stent completion, where you extend the stent to the proximal part. This called the stented part of the frozen elephant trunk. There is a small unstented part and there is a distal landing zone. These are all the various options available for an aneurysm. So you do an interpositional graft with head and neck vessel inserted as an island, or you do a one stage repair. Insert a large conduit, you have the proximal part, the vessel inserted, and the distal anastomosis. And classical stage 1 is you put a prosthetic graft through surgery and insert an elephant trunk graft, and you have the proximal part and there is a distal free end. At the second stage, you do a surgery and suture the you suture the distal end of the elephant trunk, or you insert a stent at the distal end. This is stage 2, either with stent or with surgery. Or finally, you can have what is called the frozen elephant trunk, where you have the distal landing zone for the distal part, and there is a proximal anastomosis, and there is a small unstented part of the frozen elephant trunk. These are all the various procedures which is available for the arch aneurysm. So the requirement for doing this hybrid procedure is the aortic arch pathology should be amenable to undergo an endovascular repair. concurrent or staged open debranching procedures such as carotid or carotid subclavian bypass. All the three vessels should be taken care of. Debranching permits deployment across the origin of the arch vessels while maintaining the perfusion to head and upper extremities. This is very, very important. Your perfusion to the head and upper extremities should be taken care of by debranching these three origin vessels from the arch. And here you can see the snorkel shunt which extends from the ascending aorta into the innominate artery. The snorkel shunt maintains the flow to the carotid and the subclavian artery and allows deployment of the stent graft in the proximal landing zone. Here you can see the proximal landing zone of the stent graft. And whenever you look at the hybrid arch, you have to take the measurement of all the vessels. Okay. Innominate artery length and the diameter, your left common carotid artery length and diameter, your subclavian artery diameter and length, and the sinotubular junction and the ascending aorta diameter and the length. Another important thing is the aneurysm diameter and length. These are all very important measurement. Accordingly, you can decide about the stent placement, landing zone and the debranching of the various vessels. Now coming to the landing zone. If the landing zone of the proximal stent is going to be in zone 1 or in zone 2, you can do median without sternotomy. But if it is going to be in landing zone 0, that is in the ascending aorta, you have to go with the median sternotomy. And if it is going to be in zone 1 and 2 or not affecting the part between the coronary annulus and the coronary artery, you can do without cardiopulmonary bypass. But if it is going to involve the coronaries and the annulus, cardiopulmonary bypass is required. And TEVAR can be done on the same day if cardiopulmonary bypass is not involved. And TEVAR has to be done on the following days if cardiopulmonary bypass is being utilized. This is the normal course to follow the hybrid arch repairs depending upon the landing zone and whether you use cardiopulmonary bypass or not and whether you use sternotomy or not. And coming to few pathologies. Here you can see chronic type B dissection. The landing zone is going to be zone 1 between the innominate and the left common carotid. Here you can see an enlarging aneurysm due to endoleak. Here the proximal landing zone is zone 3 just distal to the subclavian. You have an isolated arch aneurysm which is involving the subclavian. Here you have to go as proximal as possible. Most probably the landing zone will be in zone 0 between the ascending aorta and the innominate artery. Or you have an ascending aortic pseudoaneurysm leaking patch due to previous aortic cannulation. The patient has undergone cardiopulmonary bypass before and there is a leaking ascending aortic aneurysm which is causing a pseudoaneurysm. Here the proximal landing zone will be zone 0. And if we have a penetrating posterior ulcer in the aortic arch, the landing zone will be between innominate and the left common carotid artery, that is zone 1. A ruptured aortic aneurysm, always in ruptured aortic aneurysm, the landing zone will be between the ascending aorta and the innominate artery. And there is an enlarged aortic aneurysm following a endoleak after TEVAR. Here you can see the aneurysm enlarging after an endoleak. Here the landing zone will be between zone 1, that is innominate and the common carotid artery. And coming to hybrid arch repair, there are 3 types of repair, that is type 1, type 2 and type 3. In type 1, you do a supra-aortic debranching followed by TEVAR. Here you can see the 3 branches being taken care of and then TEVAR is being done. You can see the endovascular stent placed. In type 1, TEVAR is primary followed by surgery. In type 2, you do a ME arch In type 3, you do a complete arch replacement. So here the surgery becomes primary. Conventional ME arch or arch, the surgery becomes primary and the TEVAR procedure becomes secondary. Here the TEVAR becomes secondary. In type 1, TEVAR is primary and surgery is secondary. In type 2 and type 3, that is ME arch and arch replacement, surgery becomes primary, TEVAR becomes secondary. Coming to anesthesia management, anesthesia management facilitates precise deployment of stent at short proximal landing zone. There is only small area through which the proximal stent is being deployed, and these areas are very small. So your anesthetic management should facilitate the landing zone in an appropriate, precise location it should be landed. For that, anesthesia management plays a major role. And this deployment is complicated by the hydrodynamics of the aortic blood, which comes from the left ventricle and goes into the arch. See, the blood from the left ventricle comes from the ascending aorta and goes to the arch, and the blood from the left ventricle is being pushed. So this forces, as a windsock effect, make the landing zone slightly difficult. The proximal landing can be difficult because of the blood coming so forcefully from the left ventricle. So at this time, we have to induce hypotension so that the blood pressure is not very high and landing happens smoothly. There, the anesthesiologist plays a major role. He reduces the blood pressure to around 60 millimeter of mercury during deployment so that stent migration or stent mobilization doesn't happen. Once landing happens, you get the blood pressure back to normal. This transient hypotension can be induced by two ways. One is pharmacological, another is the rapid ventricular pacing. And rapid ventricular pacing is the usually preferred method. It provides more profound hypotension quickly and shorter duration as compared to nitroprusside. Immediately, once you induce rapid ventricular pacing, the blood pressure drops drastically and it happens very fast so that you can put the stent at the proper landing zone. Now coming to pharmacological reduction of blood pressure, adenosine can be used to induce transient asystole in TEVAR as well as in intracranial procedure. But the problem with the adenosine is it can cause an unpredictable duration of asystole and there is lot of individual variation in dose requirement. And what happens with the adenosine, there can be an unexpected return of left ventricular contraction, and before the stent deployed, the drug might wear off and the patient might have an unexpected return of ventricular contraction which may delay the stent deployment. Unlike pharmacological technique, the onset and duration of rapid ventricular pacing can be controlled precisely. You can have the control and you can decide how long the rapid ventricular pacing is needed. However, not much data on rapid ventricular pacing for stent deployment. Rapid ventricular pacing are mostly used for TAVI but not for stent deployment. Coming to morbidity, there can be operative morbidity because it is an hybrid procedure. You have surgery combined with the endovascular treatment. So most of the time, it is an operative mortality of complex operation. There is minimal post-operative and long-term endoleak rate. Neurological complication includes stroke and spinal cord ischemia, and this is a very significant cause for morbidity and associated mortality. One complication which is present with the hybrid arch repair is the neurological complication, and spinal cord ischemia is the worst thing to happen in case of hybrid arch repair. So to conclude, hybrid approach for aortic arch aneurysmal pathology are being performed with increasing frequency. With the advancing endovascular technology, there is increasing comfort level for surgeon. The most important part is get the stent in the proper landing zone. There, anesthesiologists play a major role and he has to reduce the pressure accordingly so that the proximal stent lands in the appropriate landing zone. As the patient population with thoracic aortic disease seeking intervention gets older, embracing and honing these skills will be crucial, and anesthesiologist has to be familiar with this hybrid arch procedures. Thank you.